Major factors that decrease risk are early pregnancy, prior to 20 years of age, and prolonged breastfeeding. Societal changes in these factors in low-income countries are thought to be contributing to the rise in breast cancer incidence. Surgical and medical interventions also can decrease risk. Bilateral prophylactic mastectomy decreases risk by about 90%. Chemoprevention using ER antagonists decreases the incidence of ER-positive cancers. These interventions are mainly offered to women at very high risk for breast cancer, molecular classification, and pathogenesis. Several different approaches have been used to subclassify breast cancer into clinically meaningful subtypes. Based on gene expression profiling, breast cancers cluster into three main groups: luminal, predominantly ER-positive, HER2-negative, HER2-enriched, predominantly HER2-positive, and basal-like, predominantly ER-negative, HER2-negative. Because these molecular subtypes correlate reasonably well with ER and HER2 protein expression, figure 23.13, which is easily assessed by standard clinical assays. Molecular subtyping by expression profiling is not a routine part of breast cancer classification. Like other cancers, breast cancers arise through several pathways that involve the stepwise acquisition of driver mutations in epithelial cells. Breast cancer develops in a hormonal milieu that facilitates mutagenesis and the outgrowth of abnormal clones. Carcinomas associated with germline mutations in cancer genes make up the minority of carcinomas, but provide generally important insights into the molecular pathogenesis of breast cancer. Thus, we begin by discussing tumors with a strong familial basis and then turn to sporadic breast cancers. Pathogenesis of familial breast cancer. It is believed that 1/4 to 1/3 of breast cancers occur due to inheritance of a susceptibility gene, or genes. Single gene mutations with moderate to high penetrance refers to the risk of an individual with a mutated gene developing cancer, accounts for 8% to 17% of breast carcinomas, table 23.3. Inheritance also is thought to play a role in an additional 15% to 20% of women based on a positive family history, defined as an affected first-degree relative mother, sister, or daughter, cancer in multiple relatives, and early onset cancers. In these women, inheritance of a single susceptibility gene with low penetrance or combinations of genes that interact to increase risk is believed to be the culprit. The most important high-penetrance susceptibility genes for familial breast cancer are tumor suppressor genes that regulate genomic stability or are involved in pro-growth signaling pathways. See table 23. Risk is inherited in an autosomal dominant fashion and stems from alleles with loss-of-function mutations. As with other tumor suppressor genes, cancer development is associated with sporadic loss-of-function mutations in the single normal copy of the gene. Mutations in BRCA1 and BRCA2 are responsible for 80% to 90% of single-gene familial breast cancers and about 3% to 6% of all breast cancers. Penetrance, age of onset, and susceptibility to other types of cancers vary according to the specific BRCA1 and BRCA2 mutation that is inherited, but most carriers develop breast cancer by the age of 70 years. Mutations in BRCA1 also markedly increase the risk of ovarian carcinoma, which occurs in 20% to 40% of carriers. BRCA2 confers a smaller risk for ovarian carcinoma, 10% to 20%, but is associated more frequently with male breast cancer. BRCA1 and BRCA2 carriers also are at higher risk for other epithelial cancers, such as prostatic and pancreatic carcinoma. BRCA1 on chromosome 17q21 and BRCA2 on chromosome 13q12.3 are both large genes, and hundreds of different mutations distributed throughout their coding regions have been associated with familial breast cancer. The frequency of mutations that increase breast cancer risk is about 1 in 400 persons in the general population, and inconsequential polymorphisms are common. As a result, genetic testing is complex and is generally restricted to individuals with a strong family history or those belonging to certain ethnic groups. For example, in Ashkenazi Jewish populations, about 1 in 40 individuals carry one of 3 specific mutations, 2 in BRCA1 and 1 in BRCA2. Identification of carriers is important, since increased surveillance and prophylactic mastectomy and salpingo-oophorectomy can reduce cancer-related morbidity and mortality. One-associated breast cancers are commonly poorly differentiated, often have characteristic morphologic features described later, and usually fall in the TNBC subgroup. BRCA2-associated breast carcinomas also tend to be poorly differentiated, but are more often ER-positive than BRCA1 cancers. Other tumor suppressor genes associated with germline mutations that convey a high risk for breast cancer, often as part of well-described syndromes, include TP53 Lefrau-Meny syndrome, P10 Cowden syndrome, STK11, Peutz-Jeghers syndrome, CDH1 hereditary diffuse gastric cancer syndrome, and PALPB2, see table 23.3. Moderately penetrant 10% to 30% risk mutations occur in the tumor suppressor genes ATM, a cause of ataxia telangiectasia when homozygous mutations are present, and check 2. 1048. Chapter 23, HER2 negative, low proliferation, high proliferation, 171,819,200, and 2,122, XY123, 1615-4, 14-5, 13, 12-6, 11, 78,109. 171,819,200, and 2,122, XY123, 1615-4, 14-5, 13, 12-6, 11, 78,109. HER2 positive, high proliferation, 171,819,200 and 2,122, XY123, 1615-4, 14-5, 13, 278,109. Triple negative breast cancer, negative, HER2 negative. High proliferation, 171,819,200 and 2,100 and 222 XY125 and STEAM 15.4 800 proliferation genes, protein, error key 67 HER2 basal keratins. Morphology. Figure 23.13 Molecular classification of invasive breast cancer. 3 major groups of breast cancer are distinguished by characteristic changes in DNA, mRNA, protein, and morphology. Genomic abnormalities are shown in Circos plots, Chapter 7, which present a snapshot of all of the genomic abnormalities within a particular tumor. These abnormalities are mapped onto the chromosomes, which are displayed at the periphery of a circle. Green loops show intrachromosomal rearrangements, while red loops show interchromosomal rearrangements. Gene expression, mRNA. Profiling measures relative levels of mRNA expression. Red indicates a relative increase, green a relative decrease, and black no change in levels. Genes are arrayed from top to bottom and tumors from left to right. Immunohistochemical studies detect proteins using specific antibodies, visualized with a brown chromogen. Luminal or positive, HER2-negative cancers are diverse, ranging from well-differentiated cancers with low proliferative rates and few chromosomal changes to poorly differentiated cancers with high proliferative rates and large numbers of chromosomal rearrangements. All of these cancers express ER and estrogen-dependent transcription factor. Proliferation is estimated by counting mitoses or by staining for cell cycle, specific proteins such as Ki67. HER2-positive cancers may be ER-positive or ER-negative, but when ER is present, levels are typically low. HER2 positivity can be detected as an increase in HER2 gene copy number, an increase in HER2 mRNA, or an increase in HER2 protein, as shown here. Triple-negative breast cancers. ER-negative, ER2 and EGATIVE. This group largely overlaps with basal-like carcinomas defined by mRNA expression, are characterized by genomic instability denoted by numerous chromosomal changes, a high proliferative rate and expression of many proteins typical of myoepithelial cells, e.g., basal keratins. Carcinoma of the breast 1049. Comments. Gene syndrome % of single gene cancers 2. Table 23.3. Most common single gene mutations associated with hereditary susceptibility to breast cancer. Risk of breast cancer to age 70 billions other cancers. High penetrance germline mutations greater than 4-fold increased risk, 3% -7% of breast cancers. Brachy familial breast, and ovarian cancer -55%, 40% -90%. Females 1%, males. BRCA2 familial breast and -35%. Ovarian cancer -30%, -60%. Females 6%, males. TP53, Lee from any, less than 1%. P10 Cowden less than 1%. Est-Kieputz-Jeggers less than 1%. -50%, -60%, females. Less than 1%, males. -20%, -80%, females. Less than 1% males. 40% -60% females. CDHI hereditary diffuse less than 1% -50% females. Gastric cancer. PAL-PB2 hereditary breast cancer -30% -60%, females less than 1%, males less than 1%. Ovarian -20% -40%. Fallopian tube, pancreas, prostate, others. Ovarian -10% -20%, pancreas, prostate, others. Sarcoma, leukemia, brain, tumors, others. Thyroid, endometrium, others. Ovarian, colon, pancreas, others. Gastric signet ring cell, carcinoma, colon, pancreas, prostate. Moderate penetrance germline mutations 2 to 4-fold increased risk, 5% to 10% of breast cancers. ATM, ataxia telangiectasia. Check 2 hereditary breast cancer, -5%, -5%, -15%, -30% females, -10%, -30% females, prostate, thyroid, colon, kidney. Majority of cancers are TNBC. Majority of cancers are ER positive. Biallelic mutations cause a form of Fanconi anemia. Majority of cancers are ER and HER2 positive. Also associated with benign tumors. Also associated with benign colon polyps. Majority of cancers are lobular in type. Biallelic mutations cause a form of Fanconi anemia. Biallelic mutations cause ataxia telangiectasia. Majority of cancers are ER positive. The percentage of all breast cancers that are associated with a germline mutation conferring an increased risk of breast cancer. Risk for specific patients can vary with the specific mutation and the presence of other gene mutations. ER, estrogen receptor, TNBC, triple-negative breast cancer. Most of these genes play complex and interrelated roles in maintaining genomic integrity. Under normal circumstances, cells that sustain DNA damage undergo cell cycle arrest and either repair their DNA or die by apoptosis. ATM senses DNA damage and activates P53, the so-called guardian of the genome, which has a direct role in inducing cell cycle arrest and, if DNA repair is unsuccessful, apoptosis. BRCA1, BRCA2, and CHEK2 all have important functions in repair of double-stranded DNA breaks. If any of these functions are impaired, the likelihood of permanent DNA damage increases, leading to potentially oncogenic mutations that will be passed to daughter cells. What is mysterious is why malfunction of these genes, particularly BRCA1 and BRCA2, is more highly associated with breast cancer than other cancers. BRCA1 and BRCA2 are components of a large complex of proteins that are required to repair double-stranded DNA breaks through a process called homologous recombination, in which a normal sister chromatid is used as a template for repairing the DNA break. BRCA1 and BRCA2 are expressed ubiquitously, so the link to breast cancer cannot be explained by tissue-specific patterns of gene expression. An alternative possibility is that breast and ovarian epithelial cells may be particularly prone to suffer the type of DNA damage that BRCA1 and BRCA2 are required to repair. BRCA1 also interacts with protein complexes that regulate chromatin structure and has a role in transcription, and it also remains possible that its tumor suppressive role, at least in part, involves functions that are independent of DNA repair. Pathogenesis of sporadic breast cancer. As with other forms of carcinoma, multiple pathways resulting in different types of breast carcinoma have been identified. The mutation that initiates the process, as demonstrated by inherited cancers, appears to strongly influence the phenotype of the cancer that ultimately develops, as may the specific cell type in which the initiating event occurs. Pathways leading to the three major molecular types of breast carcinoma, as well as how the biologic features of these types relate to response to treatment, recurrence, metastatic pattern, and survival, are summarized in Fig. 23.14 and Table 23.4 and are described next. Luminal positive, HER2 negative cancers arise via the dominant pathway of breast cancer development, constituting 50% to 65% of cases. By gene expression profiling, ER-positive cancers fall into the luminal subgroup, a pattern of gene expression that is dominated by a large number of genes that are regulated by estrogen. Luminal breast cancer has the widest spectrum of histologic grades and proliferation rates of the three molecular types. Cancers with high expression of ER usually also express high levels of PR, which is itself upregulated by estrogen and ER. Such positive tumors are usually well differentiated and slow growing. In contrast, carcinomas with low ER and absent PR tend to lie at the other end of the spectrum, as they are typically poorly differentiated and have a high proliferative rate. The major risk factor for luminal breast cancer is estrogen exposure. See Table 23.2, which may promote the 1050. Chapter 23, the breast. Germline, BRCA, 2. Mutations familial cancers, 1q gain, normal breast, germline BRCA 1, mutations familial cancers, 16q loss, flat epithelial atypia, ER-positive pathways, germline HER2 TP53 mutations amplification familial cancers, ER-negative pathways, TP53 mutations, PIK3CA mutations, P53 signature, atypical ductal hyperplasia, no definite precursor lesion identified, BRCA1 inactivation, DCIS, invasive cancer. ER-positive, HER2-negative 50 to 65% of cancers, luminal. HER2-positive 20% of cancers, HER2, ER-negative. HER2-negative 15% of cancers. Triple-negative breast cancer. Figure 23.1. 4 major pathways of breast cancer development. 3 main pathways have been identified. The most common pathway, yellow arrow, leads to luminal or positive carcinomas. Recognizable non-obligate precursor lesions include flat epithelial atypia and atypical hyperplasia. A less common pathway, blue arrow, leads to triple-negative breast cancer, ER-negative, HER2-negative. A possible precursor lesion consisting of morphologically normal cells that overexpress P53 has been identified, analogous to the P53 signature lesions for ovarian carcinoma. The third pathway, green arrow, consists of HER2-positive cancers. Amplification of HER2 can occur in either ER-positive or ER-negative lesions. A definite HER2-positive precursor lesion has not been identified. See text for other details. DCIS, ductal carcinoma in situ, Table 23.4, defining features, percent of breast cancers. Most similar group defined by mRNA profiling B. Most common gene mutations, typical special histologic types, typical patient groups, subtypes of invasive breast cancer, luminal or positive, HER2-negative. Approximately 40%, 55%, low to approximately 10% high proliferation, moderate proliferation. Luminal, luminal, PIK, 3CA, TP, 53 12%. Grade 3 lobular. Tubular, grade 1 or 2. Lobular, mucinous, papillary. Older women, men, cancers detected by mammographic screening, less than 10%. BRCA2 mutation carriers, approximately 10%. Complete response to chemotherapy, metastatic pattern bone more. Common than viscera 25% or brain less than low rate over many years, long survival possible with bone metastases. ATNBC lacks expression of ER, progesterone receptor, and HER2. BTT, 3 major groups of cancer identified by protein expression or mRNA profiling largely overlap but are not identical. Luminal B can refer to ER-positive cancers with high proliferation with or without HER2 expression. See some rare special histologic types have a more favorable prognosis than this group as a whole, e.g. adenoid cystic carcinoma, secretory carcinoma, low-grade adenosquamous carcinoma. ER, estrogen receptor, mRNA, messenger RNA, TNBC, triple-negative breast cancer. Molecular. ER-positive approximately 15, ER-negative approximately 30-60%. Bone, viscera, and brain 30%, all are common. Bimodal with early and late 10 years peaks. Bone, viscera, and brain 25%, all are common. Early peak at less than 8 years, late recurrence rare, survival. With metastases rare. Bone 80%, more common than viscera 30% or brain. Early peak at less than 10 years, late recurrence possible. Relapse pattern. HER2 positive. Approximately 20%. HER2 enriched or negative, luminal B or positive. PIK, 3CA, TP53. 70% some apocrine, some micropapillary. Young women, TP53. Mutation carriers, positive. TNBC or negative, HER2 negative, 15%, basal-like. PIK, 3CA, TP53. 70% medullary features metaplastic. Young women, women of African heritage, BRCA1 mutation carriers. Approximately 30%. Carcinoma of the breast 1051. Development of breast cancer through several mechanisms. Estrogen increases the local production of growth factors, such as transforming growth factor, platelet-derived growth factor, and fibroblast growth factor, and regulates the expression of dozens of genes in breast epithelial cells that may directly contribute to tumor growth and development. Estrogen exposure also stimulates the proliferation of breast epithelial cells during puberty, menstrual cycles, and pregnancy, thereby increasing the number of cells that are at risk for transformation. The DNA replication that attends cellular proliferation is conducive to the accumulation of mutations, and the lull in cell division that occurs during the latter part of the menstrual cycle may allow time for defective DNA repair to occur and for mutations to become fixed in the genome. Repetition of this process during each cycle may underlie the association between the cumulative number of menstrual cycles a woman experiences and her risk of developing breast cancer, as well as the strong association between luminal cancers and age, see Figure 23.12. A clear measure of the importance of estrogen is found in the therapeutic benefits of estrogen antagonists, which reduce the development of luminal cancers in women at high risk, and the increased incidence of luminal cancers in women treated with postmenopausal hormone therapy. Once a clonal population of mutated ER-positive cells emerges, estrogen may also enhance the transformation of such precursor lesions to fully malignant cancers. ER-positive precursor lesions include flat epithelial atypia and atypical ductal and lobular hyperplasia. All of these may be associated with genomic changes found in invasive carcinomas, including gains of chromosome 1q, losses of chromosome 16q, and activating mutations in PIK3CA, the gene that encodes phosphoinositide 3-kinase PI3K, which you will recall is an important component of signaling pathways downstream of growth factor receptors. Chapter 7. These are considered the earliest recognizable precursors of luminal breast cancers. It must be emphasized, however, that few of these lesions progress to malignancy, presumably because multiple additional events are needed before the cells acquire all of the hallmarks of cancer. The precursor lesions mentioned above are mainly associated with the development of luminal cancers, with low growth fractions and indolent clinical behavior. Such tumors, by gene expression profiling, belong to the luminal A subgroup, see Figure 23.13. More aggressive, high-grade luminal cancers also occur and cluster within the luminal B subgroup, defined by high levels of expression of genes associated with proliferation. These aggressive forms of luminal cancer share some genomic changes with low-grade carcinomas, but tend to have a greater burden of chromosomal aberrations. They sometimes arise from low-grade luminal cancers following the acquisition of mutations in genes that regulate genomic stability, such as TP53, and also frequently occur in patients with germline BRCA2 mutations. Cancers detected by mammographic screening are usually small luminal cancers limited to the breast, see Table 23.4. These cancers typically respond well for many years to anti-estrogen therapy and have a more favorable outcome than the other types of breast cancer. The rate of recurrence is low, and even when these carcinomas metastasize, most often to bone, they often can be held in check for a decade. 7%. Metastasis. Distant. 4. Rate. Hazard. Annual 1. 65432. Figure 23.15. Each molecular group of breast cancer has characteristic patterns of recurrence over time. Luminal or positive cancers have the lowest rate of recurrence in the first 10 years, but recurrences continue with a steady rate over a long period of time. In contrast, almost all recurrences of triple-negative breast cancer, ER-negative, HER2-negative, occur within the first 8 years. Recurrences after this time are rare. HER2-positive cancers show a mixed pattern with both early and late peaks, although not yet fully explained. A late peak may be due to acquired resistance to targeted therapy or to selection of HER2-negative tumor cell populations, or longer by treatment with antiestrogens. Figure 23. Fertitine. By contrast, cytotoxic chemotherapy provides little benefit, particularly in treating luminal A cancer with low growth fractions. Some luminal cancers eventually escape from estrogen dependence through several mechanisms, including outgrowth of clones that lack ER expression, compensatory alterations in related growth factor signaling pathways, or acquisition of mutations in the ER gene ESR1 that lead to estrogen-independent ER function. HER2-positive cancers arise through a pathway that is strongly associated with amplification of the HER2 gene on chromosome 17q. HER2, also known as ERBB2, is a receptor tyrosine kinase that promotes cell proliferation and opposes apoptosis by stimulating the RAS and PI3K AKT signaling pathways. Cancers with HER2 amplification constitute approximately 20% of all breast cancers and may be either ER-positive or ER-negative. This is the most common subtype of breast cancer in patients with germline TP53 mutations, Li-Fraumeni syndrome. The only common molecular mechanism for HER2 overexpression is gene amplification, found in greater than 95% of HER2-positive carcinomas. The size of the amplicon varies and typically includes at least 10 adjacent genes, some of which may cooperate with HER2 to promote tumor growth. In addition, these cancers characteristically have complex interchromosomal rearrangements and a high mutational load. The gene expression profile of HER2 cancers is dominated by transcripts encoded by HER2, CO-amplified genes, and genes involved in pro-growth signaling pathways and proliferation. Variation in gene expression among HER2 cancers is largely based on their ER status and differing levels of expression of ER-regulated genes. Triple-negative breast cancer. HER2, luminal, 02468 1012. Time after initial breast cancer diagnosis, years. HER2 copy number, HER2 protein, CEP17, HER2 negative. 1717, HER2 positive, 17, Figure 23. Identification of HER2-positive breast cancer. HER2 protein overexpression is virtually always caused by amplification of the region of chromosome 17q that contains the HER2 gene. The increase in HER2 gene copy number is detected by fluorescence in situ hybridization using a HER2-specific probe, red signal, which is typically co-hybridized to tumor cell nuclei with a second probe specific for the centromeric region of chromosome 17, green signal, allowing the chromosome 17 copy number to be determined. Alternatively, HER2 protein overexpression in tumor cells can be detected by immunohistochemical staining with antibodies specific for HER2. Clinically, HER2 carcinomas are diagnosed by detecting HER2 overexpression by immunohistochemistry, or HER2 gene amplification by in situ hybridization, figure 23:16. Before the implementation of HER2-targeted therapy, HER2-positive cancers had a poor clinical outcome. However, greater than half of patients with HER2 carcinomas have complete remissions when treated with antibodies that bind and block HER2 activity. Such patients have an excellent prognosis. See Table 23.4. The remarkable efficacy of this form of therapy proves the importance of HER2 as an oncogenic driver. However, not all HER2-positive carcinomas respond to targeted therapy, and some that initially respond become resistant. See Figure 23:15. Multiple mechanisms of resistance to HER2 antagonists have been defined in cancers, and numerous therapeutic agents are under investigation in an effort to both improve response and overcome resistance. TNBCs arise through an estrogen-independent pathway that is not associated with HER2 gene amplification. They comprise about 15% of breast cancers and have a basal-like gene expression profile, so-called because many of the genes that comprise this signature are normally expressed in basally located myoepithelial cells. A possible precursor lesion has been identified that consists of lobular epithelial cells that are ER negative and P53 positive, the latter being a feature that correlates with the presence of TP53 mutations. These lesions resemble serous tubal intraepithelial carcinoma, the proposed precursor to serous carcinoma that is seen in the fallopian tubes of women with germline BRCA1 mutations. See Chapter 22. As might be expected based on this similarity, TNBC also is associated with germline BRCA1 mutations. TNBC also shares other genetic features with serous ovarian carcinoma. Both are characterized by marked genomic instability due to defects in DNA repair by homologous recombination that manifests as complex copy number alterations and chromosomal rearrangements. In familial breast cancer, this defect is often related to germline BRCA1 and BRCA2 mutations. BRCA1 mutations are rare in sporadic TNBC, but BRCA1 is instead often silenced through epigenetic mechanisms and allelic loss. The only gene that is mutated in the majority of these cancers is TP53. Presumably, other genes that contribute to the malignant phenotype are dysregulated by copy number variation or gene rearrangements. Compared with luminal cancers, TNBC is more likely to present as a palpable mass and is less likely to be detected by mammographic screening. See Table 23. Cytotoxic therapy combined with agents that are selectively active against cancers with defective homologous recombination results in complete or almost complete responses in about a third of cases. The cancers that recur usually do so in the first 8 years after diagnosis. See Figure 23. Metastases are often to visceral sites and brain and frequently result in death. Patients who survive 10 years are likely cured, as late recurrences are unusual. Development of more effective treatments for this breast cancer subtype has been challenging, as obvious drug targets such as ER or HER2 are lacking. In addition, the genomic instability of these tumors leads to profound genetic heterogeneity, increasing the likelihood of emergence of more aggressive, therapy-resistant subclones. However, genomic instability also may lead to expression of tumor neoantigens, and one approach that shows some carcinoma of the breast 1053 promise in TNBC is use of immune checkpoint inhibitors, see Chapter 7, which are under evaluation in numerous clinical trials. Finally, it must be said that as with other carcinomas that begin as in situ lesions, it is not clear what drives transition of any of the molecular subtypes of breast cancer from innocuous in situ lesions to potentially lethal invasive cancers. Maintenance of the basement membrane depends on the interaction of luminal cells, myoepithelial cells, and stromal cells in the local microenvironment. The majority of genomic changes observed in invasive carcinoma also are already present in carcinoma in situ, including major driver mutations, and genomic changes specific to invasive carcinoma have not been identified, suggesting that invasion may depend on changes in stromal cells rather than tumor cells. For example, in some in situ cancers, myoepithelial cells are mislocalized and reduced in number, and the associated basement membrane is thin and has gaps. Such changes may set the stage for stromal invasion by breast cancer cells. Stromal invasion also may expose cancer cells to increased host immune surveillance, and it may also be that alterations that enable cancer cells to evade the host immune response are necessary before effective invasion can occur. With this as background, we next turn to discussion of the pathology of breast cancer. Key concepts: carcinoma A of the breast. Breast cancer is the most common non-skin malignancy in women and the second most common cause of cancer deaths in the United States. The most important risk factors for sporadic cancers in women are estrogenic stimulation and age. Approximately a quarter to a third of breast cancers are familial, being related to inheritance of genetic variants that increase breast cancer risk. High-risk genes associated with familial breast cancer include several involved with DNA repair and genomic stability, most notably BRCA1, BRCA2, and TP53. Breast cancers cluster into three major molecular groups: luminal, positive, HER2, and triple negative, each with distinctive biologic and clinical features. Luminal cancers are further divided into two groups, A and B, that differ mainly in terms of proliferation, which is low in group A and high in group B. HER2 cancers are defined by overexpression of the HER2 receptor, usually due to HER2 gene amplification, and respond well to HER2 inhibitors. TNBCs lack ER and HER2 expression are often associated with defects in DNA repair or genomic stability, e.g. due to silencing a BRCA1 or TP53 mutation, and carry a relatively poor prognosis. Types of breast carcinoma. Almost all breast malignancies are adenocarcinomas. The terms ductal and lobular are still used to describe subsets of both in situ and invasive carcinomas. But most evidence suggests all breast carcinomas arise from cells in the terminal duct lobular unit. Carcinoma in situ was originally classified as ductal carcinoma in situ, DCIS, or lobular carcinoma in situ, LCIS, based on the resemblance of the involved spaces to normal ducts or lobules. But it is now recognized that these growth patterns are not related to the cell of origin, but rather reflect differences in tumor cell genetics and biology. By current convention, lobular refers to invasive carcinomas that are biologically related to LCIS, and ductal is used more generally for adenocarcinomas that cannot be classified as a special histologic type. Carcinoma in situ, carcinoma. In situ, literally carcinoma in its original place, refers to cancer cells confined within ducts and lobules by a basement membrane. This type of cancer has no capacity to metastasize, as the location precludes access to blood vessels and lymphatics. Because many, if not all, of the molecular changes found in invasive carcinomas also are found in these lesions, carcinoma in situ is an apt description. Ductal carcinoma in situ. DCIS is a clonal proliferation of epithelial cells limited to ducts and lobules by the basement membrane. Myoepithelial cells are preserved in involved ducts, lobules, although they may be diminished in number. DCIS can spread throughout the ductal system and produce extensive lesions involving an entire sector of a breast. DCIS is almost always detected by mammography. Without mammography, fewer than 5% of carcinomas detected are in situ lesions, but this rises to 15% to 30% in screened populations. Most are identified as a result of calcifications associated with secretory material or necrosis. Less commonly, periductal fibrosis surrounding DCIS results in a mammographic density or creates a vaguely palpable mass. Rarely, DCIS, often of micropapillary or papillary types, produces a nipple discharge or is detected as an incidental finding upon biopsy for another lesion. Morphology. DCIS grows in several architectural patterns, which vary in nuclear grade and the presence and extent of necrosis. Figure 23:17. Some cases of DCIS have a single growth pattern, but most are comprised of a mixture of patterns. Comedo DCIS may occasionally produce a vague nodularity, but more often is detected as clustered or linear and branching areas of calcification. Figure 23. It is defined by two features: 1, tumor cells with pleomorphic, high-grade nuclei, and 2 areas of central necrosis. Figure 23:17b. Cribriform DCIS has rounded, cookie-cutter-like spaces, often filled with calcified secretory material. Figure 23:17. Micropapillary DCIS produces complex bulbous protrusions without fibrovascular cores. Figure 23, papillary DCIS produces true papillae with fibrovascular cores that lack a myoepithelial cell layer. Varying degrees of necrosis can be associated with each architectural pattern as well as calcifications, which develop in association with intraluminal secretions or necrosis. Paget disease of the nipple is a rare manifestation of breast cancer, 1% to 4% of cases, that presents as a unilateral erythematous eruption with a scale crust. Pruritus is common, and the lesion may be mistaken for eczema. Malignant cells, Paget cells, extend from DCIS within the ductal system via the lactiferous. Chapter 23. The breast, a BCD. Figure 23. Ductal carcinoma in situ DCIS, A and B, Comedo type, A. Specimen radiograph reveals linear and branching calcifications within the ductal system. B. High-grade proliferation associated with large central zones of necrosis and calcifications fills several ducts. C. Cribriform DCIS. Note the round, regular, cookie-cutter spaces containing calcifying secretory material. D. Micropapillary DCIS. The papillary projections lack fibrovascular cores. Sinuses into nipple skin without crossing the basement membrane. Figure 23:18. The tumor cells disrupt the normal epithelial barrier, allowing extracellular fluid to seep out onto the nipple surface. Paget cells are readily detected by nipple biopsy or cytologic preparations of the exudate. A palpable mass is present in 50% to 60% of women with Paget disease, and almost all of these masses prove to be invasive carcinoma. The carcinomas are usually ER negative and overexpress HER2. In contrast, the majority of women without a palpable mass have only DCIS. Prognosis depends on the features of the underlying carcinoma and is not affected by the presence or absence of Paget disease. 1054. Clinical features. The natural history of DCIS has been difficult to determine because in the past all women were treated with mastectomy, and the current practice of surgical excision, usually followed by radiation, is largely curative. If untreated, women with small, low-grade DCIS develop invasive cancer at a rate of about 1% per year. When invasive cancer develops in the same breast quadrant, it tends to have a similar grade and expression pattern of ER and HER2 as the associated DCIS. Patients with high-grade or extensive DCIS are believed to have a higher risk for progression to invasive carcinoma. Remarkably, the overall death rate for women with DCIS is lower than that for women in the population as a whole. Carcinoma of the breast 1055. Paget cells in the epidermis, scale crust on skin surface, dysfunction of E-cadherin, a transmembrane protein that contributes to the cohesion of normal epithelial cells in the breast and other glandular tissues. E-cadherin functions as a tumor suppressor protein in such tissues and may be lost in neoplastic proliferations through a variety of mechanisms, including mutation of the E-cadherin gene, CDH1. In rare cases, there is dysregulation of other proteins, such as catenins, that are also needed for E-cadherin-mediated cellular cohesion. LCIS associated with invasive carcinoma shares the same mutations, and thus, in some cases, is a true precursor lesion. Basement membrane morphology. Duct involved by DCIS. Figure 23.18 Paget disease of the nipple. Ductal carcinoma in situ DCISs arising within the ductal system of the breast can extend up the lactiferous ducts and into the skin of the nipple without crossing the basement membrane. The malignant cells disrupt the normally tight squamous epithelial cell barrier, allowing extracellular fluid to seep out and form an oozing, scaly crust. Classically, LCIS consists of a uniform population of cells with oval or round nuclei and small nucleoli involving ducts and lobules, figure 23. Mucin-positive signet ring cells are commonly present. The lack of E-cadherin results in a rounded shape without attachment to adjacent cells. Figure 23.19b. Pagetoid spread defined by the presence of neoplastic cells between the basement membrane and overlying luminal cells is commonly seen in breast ducts, but Paget disease, involvement of nipple skin, does not occur. Necrosis and secretory activity are not seen, and thus calcifications are absent. LCIS almost always expresses ER and PR and is HER2 negative, possibly because mammographic screening is a marker for better access to medical care or other socioeconomic factors that are associated with longevity. Death from metastatic breast cancer after a diagnosis of DCIS occurs in 1% to 3% of women. The origin of metastatic disease may be from a subsequent invasive carcinoma in the ipsilateral or contralateral breast or occult foci of invasion that were not detected at the time of DCIS diagnosis. Mastectomy is curative in greater than 95% of women. Breast conservation is appropriate for most women, but has a slightly higher risk of recurrence, about half of which are DCIS and half invasive carcinoma. The major risk factors for recurrence are 1. High nuclear grade and necrosis, 2. Extent of disease, and 3. Positive surgical margins. Ensuring complete excision of DCIS is not straightforward, since its distribution in the breast is not reliably predicted by imaging, and it is usually not grossly evident at surgery. Postoperative radiation therapy and tamoxifen also reduce the risk of recurrence. Such treatments are reserved for cases that are deemed to be at particularly high risk of recurrence. Trials to identify patients who can safely undergo observation rather than treatment are ongoing. Lobular carcinoma in situ. LCIS is a clonal proliferation of cells within ducts and lobules that grow in a discohesive fashion. It is almost always an incidental biopsy finding, since it is rarely associated with calcifications or stromal reactions that produce mammographic densities. As a result, the incidence of LCIS 1% to 6% of all carcinomas has been unchanged by the introduction of mammographic screening. When both breasts are biopsied, LCIS is bilateral in 20% to 40% of cases, compared with 10% to 20% of cases of DCIS. The cells of atypical lobular hyperplasia, LCIS, and invasive lobular carcinoma are morphologically identical. The observed loss of cellular adhesion is usually due to LCIS is a risk factor for developing invasive carcinoma in either breast, with a slightly higher risk to the ipsilateral breast. Invasive carcinoma develops at a rate of about 1% per year, similar to that observed for untreated DCIS. However, unlike DCIS, it is unclear if surgical removal of the identified lesion lowers risk. Invasive carcinomas developing in women after LCIS are threefold more likely to be lobular carcinoma. However, most are of other morphologies. Treatment choices include bilateral prophylactic mastectomy, tamoxifen, or, more typically, close clinical follow-up and mammographic screening. Invasive infiltrating carcinoma. Breast carcinoma has a wide variety of morphologic appearances. About 1/3 can be classified into special histologic types that merit discussion because they have important biologic and clinical associations. We will first cover infiltrating carcinomas of no special type, typical ductal carcinomas, and will then discuss those that fall into special categories. Morphology. The majority of invasive breast cancers are ductal adenocarcinomas that are not classified further into a special type. In the absence of mammographic screening, these carcinomas usually present as a mass of at least 2 to 3 centimeters in size. The mammographic and gross appearance varies widely depending on the stromal reaction to the tumor, figure 23.20. They most commonly present as a hard, irregular radiodense mass, figure 23.20a, associated with a desmoplastic stromal reaction, figure 23. When cut or scraped, such tumors typically produce a characteristic grating sound, similar to cutting a water chestnut due to small central pinpoint foci or streaks of chalky white desmoplastic stroma and 1056, Chapter 23, the breast. A B, figure 23. Lobular carcinoma in situ LCISs. A. Monomorphic population of small, rounded, loosely cohesive cells fills and expands the acini of a lobule. The underlying lobular architecture can still be recognized. The cells extend into the adjacent duct by pagetoid spread. B. Immunoperoxidase study shows E-cadherin positive normal luminal cells that have been undermined by E-cadherin negative LCIS cells spreading along the basement membrane. Occasional foci of calcification. Less commonly, tumors present as deceptively well circumscribed, figure 23. D. E masses composed of sheets of tumor cells with scant stromal reaction, figure 23. Figure 20 is imperceptible. Figure 20 being comprised of scattered neoplastic glands or single tumor cells infiltrating otherwise unremarkable fibrofatty tissue, figure 23. 20I. Larger carcinomas may invade the pectoralis muscle and become fixed to the chest wall or invade the dermis and cause retraction, dimpling of the skin. The tumor involves the central portion of the breast. Retraction of the nipple may develop. Rarely, breast cancer presents as metastasis to an axillary lymph node or a distant site before cancer is detected in the breast. In such cases, the primary carcinoma may be small, may be obscured by dense breast tissue, or may fail to produce a desmoplastic response. In most cases, these occult primary tumors, which are easily missed by palpation or mammography, can be detected by imaging studies using ultrasound or MRI. Invasive carcinoma is graded using the Nottingham histologic score. Carcinomas are scored for tubule formation, nuclear pleomorphism, and mitotic rate. Grade 1. Well-differentiated carcinomas. Grow in a tubular or cribriform pattern, have small uniform nuclei, and have a low proliferative rate. Figure 23. Grade 2. Moderately differentiated carcinomas have areas where cells grow as solid clusters or single infiltrating cells and show greater nuclear pleomorphism, and high numbers of mitotic figures. Figure 23, 21b. Grade 3. Poorly differentiated carcinomas invade as ragged nests or solid sheets of cells and have enlarged irregular nuclei. A high proliferative rate and areas of tumor necrosis are common in high-grade tumors. Figure 23, 21c. Special histologic types of invasive carcinoma. As with all breast cancers, these special tumors can be organized into molecular groups based on expression of ER and HER2, which carry their usual therapeutic implications. However, special histologic types of breast cancer often harbor unique genetic aberrations, sometimes have distinct gene signatures, and frequently show associations with clinical behavior and prognosis that break the established rules for ductal carcinomas of no special type. Although relatively uncommon, study of these tumors has also provided important insights into breast cancer pathogenesis. Lobular carcinoma is the subtype with the clearest association of phenotype and genotype. Like LCIS, most cases show biallelic loss of expression of CDH1, the gene that encodes E-cadherin. Lobular carcinomas are discohesive, typically infiltrate as single cells, and sometimes fail to produce a desmoplastic response, making it difficult to detect these cancers by palpation and imaging. They also have distinctive patterns of metastatic spread, often involving the peritoneum and retroperitoneum, the leptomeninges, carcinomatous meningitis, the gastrointestinal tract, and the ovaries and uterus. Males and females with heterozygous germline mutations in CDH1 are at increased risk for developing lobular carcinoma and have a greatly increased risk for signet ring carcinoma of the stomach. Chapter 17. Carcinomas with medullary pattern are of interest due to the finding that over half of BRCA1 associated carcinomas have this appearance. See Table 23.3. Although the majority of carcinomas with medullary pattern are not associated with germline BRCA1 mutations, hypermethylation of the BRCA1 promoter leading to downregulation of BRCA1 expression is observed in 67% of these tumors. Of interest, this subtype has a better prognosis than other poorly differentiated carcinomas. Notably, these tumors also have unusually large number of infiltrating T lymphocytes, suggesting that improved outcomes may be related to a host immune response to tumor antigens. Many other special histologic types of breast cancer, too numerous to list, have been described. There is much that remains to be learned about the biology and pathogenesis of these tumors, some of which are described below. Morphology. Some special histologic types of cancer almost always fall within the luminal or positive HER2 negative group. These include lobular carcinoma, mucinous carcinoma, tubular carcinoma, and papillary carcinoma. Lobular carcinoma often, as already mentioned, insidiously infiltrates the breast while producing minimal. Carcinoma of the breast 1057, ABCDEFGHI. Figure 23.20, invasive carcinoma of no special type. The majority of invasive carcinomas have a haphazard pattern of stromal invasion that produces masses with irregular margins on imaging A and gross examination B. Microscopically, such tumors are marked by an exuberant desmoplastic stromal response C. A subset of carcinomas grow as masses that appear to be well circumscribed or lobulated on imaging D and gross inspection E. Microscopically, such cancers typically take on the appearance of expansile masses of cells with pushing borders. Stromal response is often limited to a narrow zone of fibrosis at the tumor margin F. Rarely, invasive cancers produce little or no stromal response. Such cancers may show only subtle architectural distortion on mammography G, and may not produce palpable masses or be identifiable grossly H. Microscopically, tumor cells are found scattered within normal-appearing fibroadipose tissue I. B. Courtesy Dr. David Hicks, University of Rochester Medical Center, Rochester, NY. Desmoplasia. The histologic hallmark is the presence of discohesive infiltrating tumor cells, often including signet ring cells containing intracytoplasmic mucin droplets. Figure 23, 2a. Tubule formation is absent. Mucinous colloid carcinoma is soft or rubbery and has the appearance and consistency of pale gray-blue gelatin. The borders are pushing or circumscribed. The tumor cells are arranged in clusters and small islands of cells within large lakes of mucin. Figure 23, 22b. Tubular carcinoma consists exclusively of well-formed tubules and is sometimes mistaken for a benign sclerosing lesion. Figure tubiform pattern may also be present. Apocrine snouts are typical and calcifications may be present within the lumens. Papillary carcinoma, as the name, 1058, Chapter 23, the breast, a BC figure, 23.2. 1. Invasive carcinomas are separated into 3 grades based on tubule formation, nuclear pleomorphism, and number of mitoses. This example of a grade 1 well-differentiated carcinoma shows frequent tubules formed of cells with small monomorphic nuclei. Only rare mitoses are present. B. In contrast, this grade 2 moderately differentiated carcinoma shows less tubule formation and some solid nests of cells with pleomorphic nuclei. Occasional mitotic figures are seen. C. Grade 3. Poorly differentiated carcinomas infiltrate as ragged sheets of cells with enlarged pleomorphic nuclei. Implies produces true papillae, fronds of fibrovascular tissue lined by tumor cells. Figure 23, 22d. 2 special histologic types frequently overexpress HER2. The tumor cells of apocrine carcinoma resemble the cells that line sweat glands. These cells have enlarged round nuclei with prominent nucleoli and abundant eosinophilic, occasionally granular, cytoplasm, figure 23. Micropapillary carcinoma, a misnomer, forms hollow balls of cells that float within intercellular fluid, creating structures that mimic the appearance of true papillae. Figure 20. TNBC or negative, HER2 negative, often corresponds to one of several special histologic types. Chief among these is carcinoma with medullary pattern. These carcinomas are softer than other carcinomas. Medulla is Latin for marrow, due to minimal desmoplasia, and often form well-circumscribed masses. Histologic features include 1. Solid sheets of large cells with pleomorphic nuclei and prominent nucleoli. 2. Frequent mitotic figures. 3. A moderate to marked lymphoplasmacytic infiltrate surrounding and within the tumor. And 4. A pushing, non-infiltrative border, figure 23, 22, G. DCIS is minimal or not seen. Metaplastic carcinoma includes spindle cell carcinomas and matrix-producing carcinomas. These carcinomas often have gene expression profiles resembling those of myoepithelial cells. Rare special histologic types of TNBC have a favorable prognosis compared to other carcinomas in this molecular group and include secretory carcinoma, low-grade adenosquamous carcinoma, and adenoid cystic carcinoma. Secretory carcinoma mimics lactating breast by forming dilated spaces filled with eosinophilic material, figure 2322H. These carcinomas rarely metastasize. Another special subtype that merits mention is inflammatory carcinoma. This form of carcinoma has a characteristic gross appearance caused by extensive plugging of the lymphovascular spaces of the dermis with carcinoma cells, and carries a very poor prognosis, as most patients prove to have distant metastases. It presents as breast erythema, swelling, and skin thickening. The edematous skin is tethered to the breast by Cooper ligaments and mimics the surface of an orange peel, an appearance referred to as peau d'orange. The name inflammatory is a misnomer, as typically no inflammation is present. The underlying carcinoma is usually diffusely infiltrative and typically does not form a discrete palpable mass. The presentation can be confused with a breast infection, leading to delayed diagnosis. These tumors are usually of high grade, but do not belong to any particular molecular subtype. Prognostic and predictive factors for invasive carcinoma. The outcome for women with breast cancer depends on the biologic features of the carcinoma, the molecular or histologic type, and the stage of disease at the time of diagnosis. Based on these factors, some women with breast cancer have a normal life expectancy, whereas others have only a 10% chance of being alive in 5 years. Patients who present with distant metastasis, 5% of patients, or with inflammatory carcinoma, 1% to 5% of patients, have a particularly poor prognosis. For other cancers, prognosis is determined by pathologic evaluation of the primary tumor and the axillary lymph nodes, table 23.5. Prognostic factors are important in counseling patients about the likely outcome of their disease, choosing the most appropriate treatment, and designing clinical trials. Predictive factors help to determine the likely response of a cancer to a specific type of treatment. Factors related to tumor biology are usually both prognostic and predictive, e.g. ER and HER2 expression proliferation, whereas factors related to tumor extent, e.g. tumor size, lymph node metastases. Distant metastases are primarily prognostic. The major prognostic factors are as follows. Table. Lymph node metastases. Axillary lymph node status is the most important prognostic factor for invasive carcinoma. E. Carcinoma of the breast, 1059. Figure 23. Special histologic types of invasive carcinoma. A. Lobular carcinoma. B. Mucinous carcinoma. C. Tubular carcinoma. D. Papillary carcinoma. E. Apocrine carcinoma. F. Micropapillary carcinoma. G. Carcinoma with medullary pattern. H. Secretory carcinoma. See text for morphologic descriptions. Table 23.5 Prognostic factors for invasive breast carcinoma. Prognostic factors comments. Elements of AJCC 8th edition staging. Distant metastasis M. Regional lymph nodes N. Tumor T. Histologic grade expression of PR and HER2. Metastasis beyond regional lymph nodes is the most important prognostic factor. Nodal metastases, including the number of involved nodes, is the second most important prognostic factor. Size, involvement of skin, e.g., ulceration or dermal metastases, invasion into chest wall, and presentation as inflammatory carcinoma are important features. Survival diminishes with higher histologic grade. Survival is highest for the most favorable, combination high ER and PR and absent HER2, and is lowest for the least favorable combination, absent ER, PR, and HER2. Other prognostic factors: lymphovascular, invasion, special histologic, types, response to chemotherapy, gene expression, profiling. Tumor cells seen in vascular spaces at the periphery of carcinomas are a poor prognostic factor. Some histologic types of cancer are strongly correlated with very favorable survival, e.g., tubular adenoid cystic. The degree of response is a strong prognostic factor for TNBC and HER2 cancers, but not the majority of luminal cancers. The most important clinical value of these assays is to identify patients with anti-estrogen responsive cancers who do not need chemotherapy. AJCC, American Joint Committee on Cancer, ER, estrogen receptor, PR, progesterone receptor, TNBC, triple negative breast cancer. In the absence of distant metastases, the clinical assessment of lymph node status is unreliable due to both false positives, e.g., palpable reactive nodes, and false negatives, e.g., lymph nodes with small metastatic deposits. Therefore, biopsy is necessary for accurate assessment. With no nodal involvement, the 10-year disease-free survival rate is 70% to 80%. The rate falls to 35% to 40% with 1 to 3 positive nodes and to 10% to 15% when more than 10 nodes are positive. It is important to note that the presence of nodal metastases is correlated with the probability of distant metastasis, and that removal of involved lymph nodes does not lower the risk of future metastatic disease. Lymphatic vessels in most breast carcinomas drain first to 1 or 2 sentinel nodes, which can be identified with radiotracer or colored dyes. If a biopsy of the sentinel nodes is negative for metastasis, it is unlikely that other, more distant nodes will be involved. This approach is used to spare patients the morbidity of a complete axillary dissection. Approximately 10% to 20% of women without axillary lymph node metastases experience recurrence with distant metastasis. In these patients, metastasis may occur via the internal mammary lymph nodes or hematogenously. Distant metastases. Once distant metastases are present, cure is unlikely, although long-term remissions and palliation can be achieved, especially in women with ER-positive tumors. As discussed earlier, the molecular group influences the timing and location of metastases. See Table 23.4. Tumor size. The risk of axillary lymph node metastasis increases with the size of the primary tumor, but size also is an independent prognostic factor. Women with node-negative carcinomas less than 1 centimeter in size have a Chapter 23, breast. 10-year survival rate of more than 90%, whereas survival drops to 77% for cancers greater than 2 centimeters. Locally advanced disease. Carcinomas invading the skin or skeletal muscle are usually large, making it difficult to achieve local control. Such cases are now rare in the United States, but continue to be common in countries with limited access to care. Lymphovascular invasion. Tumor cells are present within vascular spaces, either lymphatics or small capillaries, in about half of all invasive carcinomas. This finding is strongly associated with the presence of lymph node metastases. It is a poor prognostic factor for overall survival in women without lymph node metastases and a risk factor for local recurrence. Inflammatory carcinoma. As already discussed, this subtype is characterized by extensive invasion of dermal lymphovascular channels and portends a poor outcome. The 3-year survival rate is only 3% to 10%. Only 1% to 5% of cancers are in this group, but the incidence is higher in women of African descent and younger women. Additional prognostic factors are related to tumor biology, see Table 23.5. Molecular subtype, histologic grade including proliferation, and special histologic types have already been discussed. A few other prognostic factors are clinically useful and merit brief mention. Gene expression profiling. A number of proprietary assays that quantify mRNA levels in breast cancer cells have been developed. Most are heavily weighted toward inclusion of genes that are involved in proliferation. The greatest clinical value of these assays is to identify patients with slowly growing, anti-estrogen responsive cancers who can be spared the toxicity of chemotherapy. Response to neoadjuvant chemotherapy. Treating patients prior to surgery provides the opportunity to observe the tumor response to chemotherapy. A third or more of TNBCs and HER2 cancers regress completely, termed a pathologic complete response. Patients with responsive cancers belonging to these subtypes have a better prognosis than patients with non-responsive cancers. In contrast, very few luminal cancers respond completely to chemotherapy. However, these tumors are typically slow-growing and can often be controlled with endocrine-based treatment for many years. The most important prognostic factors are included in the latest American Joint Committee on Cancer, AJCC staging system, which for the first time includes both an anatomic staging system, Table 23.6, and a prognostic staging system that integrates the anatomic stage and the molecular characteristics of individual breast cancers. The anatomic stage, 0 to IV, considers the nature of the disease in the breast, T for tumor, the involvement of regional lymph nodes, N for nodes, and the presence of distant metastases, M for metastases. The prognostic stage then takes into consideration biologic features that portend a more or less favorable outcome. For example, in some cases, TNBC is upstaged in the new prognostic staging system to reflect its more aggressive behavior. The main goals of breast cancer therapy are to control local disease and to prolong survival by treating known or potential distant metastases. Local control is achieved in the majority of patients with breast-conserving surgery and radiation therapy. Mastectomy is generally only necessary for locally advanced disease or for women at high risk of a second primary cancer who wish to reduce the risk of recurrence. In the absence of adequate control, some breast cancers can advance to carcinoma in cuirasse, literally carcinoma of the breastplate, a dreaded complication of infiltration of the skin and ulceration. Fortunately, this is now rarely seen in the United States, but it remains a common presentation for women living in areas with limited resources. Systemic therapy is used to treat known or likely distant disease and also reduces the likelihood of local recurrence. The first effective systemic treatment for any cancer was the discovery that oophorectomy caused regression of breast cancer in the late 1800s. This remains a treatment modality, but there are now many other options to inhibit the growth of hormonally responsive cancers, Table 23.7. For many luminal cancers, endocrine therapy is the best and most effective therapeutic option. Chemotherapy is used for highly proliferative carcinomas, regardless of molecular subtype. For HER2 cancers, targeted therapy with HER2 antagonists has markedly improved prognosis. TNBC remains a therapeutic. T-Cable. A Joint Committee on Cancer Thedation Anatomy. M. Distant 10-year. T. Primary cancer tumor. N. Lymph nodes metastasis survival. 0. Ductal carcinoma in situ, no metastases, absent 97. I. Invasive carcinoma less than or equal to 2 centimeters, no metastases, or only micrometastases, absent 87. 2. Invasive carcinoma, greater than 2 centimeters, 1, 3 positive LNS, absent 65. Invasive carcinoma, greater than 5 centimeters, but less than or equal to 5 centimeters, 0, 3 positive LNS, absent. 2. Invasive carcinoma, greater than 5 centimeters, negative or positive LNS, absent 40. Any size invasive carcinoma, greater than or equal to 4 positive LNS, absent invasive carcinoma, with skin or chest wall, negative or positive LNS, absent involvement or inflammatory carcinoma. IV, any size invasive carcinoma, negative or positive LNS, present 5. In the 8th edition, prognostic stages are assigned using T, N, M, grade, ER, PR, and HER2. Pathologic prognostic stage is assigned for patients who undergo surgical excision prior to other treatment. A multigene assay, when available, can be used to assign stage in this setting. Clinical prognostic stage is assigned for all other patients, including patients prior to surgery, patients not eligible for surgery, and patients undergoing systemic therapy prior to surgery. BD anatomic stages listed are used only when information on grade, ER, PR, and HER2 are not available. The survival estimates include the average survival for patients with all biologic types of cancer. E. Estrogen receptor, LNS, lymph nodes, PR, progesterone receptor, American, stage B, stage 1060, stromal tumors 1061, table 23.7, targeted treatment of breast cancer. Target treatment. ER estrogen deprivation, oophorectomy, aromatase inhibitors, blockage of ER tamoxifen, degradation of ER fulvestrant, cyclin-dependent kinase inhibitors, palbociclib, abemaciclib, kinases 4 and 6, ribociclib, CDK4/6, HER2 antibodies to HER2 cytotoxic therapy linked to HER2 antibody tyrosine kinase inhibitors, vaccines, defects in HRR chemotherapy with agents causing DNA damage requiring HRR, e.g., platinum agents, inhibition of alternative DNA repair pathway, PARP inhibitors, 13,000 pesos OCT, mTOR inhibition of proteins in the pathway. Activating mutations or pathway. Activation, ability to predict response under investigation, blocking antibodies to PD-L1, PDI, and other IHC for immune checkpoint proteins such as TIM1 proteins, ability to predict and lag 3 response under investigation. And mutations in BRCA1 and BRCA2 cause defects in HRR. ER estrogen receptor, HRR, homologous recombination repair, IHC, immunohistochemistry, ISH, in situ hybridization, PARP, poly-ADP ribose polymerase. Immune checkpoint proteins, companion assay, IHC for nuclear ER, IHC for membrane HER2, ISH for HER2 amplification, DNA sequencing for HER2 mutations, DNA sequencing to identify BRCA1 and BRCA2 mutations. Comments: effective cytostatic, but not cytotoxic therapy for ER-positive cancer. Used for ER-positive cancers, usually in conjunction with an aromatase inhibitor. Effective for HER2-positive cancer. May be effective in carcinomas with germline BRCA1 or BRCA2 mutations, or carcinomas with somatic loss of BRCA function. Greater than 80% of breast cancers have alterations in this pathway, under investigation for high-grade, ER-negative carcinomas. Challenge. There is hope that the genetic instability of these cancers will make them susceptible to agents that inhibit DNA repair and to immune system-based therapies. See Table 23.7. Key concepts, types of carcinoma, and prognostic factors. DCIS is treated locally, as subsequent invasive carcinomas usually occur at the same site, whereas LCIS confers bilateral risk. Special histologic types of carcinomas have prognostic importance and provide additional clues linking biologic changes to clinical behavior. Prognosis is dependent on both biologic features and the extent of cancer at the time of diagnosis. Anatomic stage. In the AJCC 8th edition staging system, molecular group and anatomic stage are combined to create prognostic stage groups that provide better estimates of likely survival. Effective treatment requires both local and systemic control of disease. Improvements in treatment are being made as new targeted therapies are being developed in response to treatment is better understood. Male breast cancer. The incidence of breast cancer in men is only 1% of that in women, which translates to a lifetime risk of 0.11%. There are about 2,670 cases and 500 deaths in the United States each year. Risk factors are similar to those in women and include increasing age, first-degree relatives with breast cancer, exposure to exogenous estrogens or ionizing radiation, alcohol consumption, infertility, obesity, prior benign breast disease, Klinefelter syndrome, and residency in Western countries. The most important familial factor conferring an increased risk for male breast cancer is germline mutation of the BRCA2 tumor suppressor gene. Approximately 6% of male carriers develop breast cancer. Of men with breast cancer, 4% to 40% have germline BRCA2 mutations depending on the population tested. A lower risk of male breast cancer is conferred by germline mutations in BRCA1, P10, TP53, and PALB2, see Table 23.3. More than 90% of breast cancers in males are of luminal type, while TNBCs and HER2 cancers are very rare, less than. Because breast epithelium in men is limited to large ducts near the nipple, carcinomas usually present as a palpable subareolar mass 2 to 3 centimeters in size, and/or as nipple discharge. Male breast carcinomas are situated close to the skin and thoracic wall, and even small tumors can invade these structures and cause skin ulceration. Dissemination follows the same pattern as in women. Axillary lymph node involvement is present in about half of cases at the time of diagnosis, and distant metastases to the lungs, brain, bone, and liver are common. Although men present with higher stage disease, the prognosis is similar to that of women when matched for stage. Most cancers are treated locally with mastectomy and axillary node dissection. The same systemic treatment guidelines are used for men as for women, and response rates are similar. Stromal tumors. The two types of stroma in the breast, intralobular and interlobular, give rise to distinct types of neoplasms. Two closely related breast-specific tumors, fibroadenoma and Phyllodes tumor, arise from cells of the intralobular stroma. Chapter 23, the breast. These tumors are termed biphasic because they also include a non-neoplastic epithelial component, the proliferation of which may be stimulated by growth factors elaborated by the stromal cells. Both fibroadenoma and Phyllodes tumor are driven by somatic mutations in MED12, a component of a multiple protein complex called mediator that links RNA polymerase II to specific DNA-binding transcription factors. It is no doubt not coincidental that the other tumor that is strongly associated with MED12 mutations, uterine leiomyoma, also arises from stromal cells within an organ that is responsive to female sex hormones. Perhaps by deranging mediator function, MED12 mutations alter the expression of sex hormone, regulated genes that control the proliferation and survival of certain types of stromal cells. In contrast, interlobular stroma is the source of the same types of tumors found in connective tissue in other sites of the body, e.g. lipomas and angiosarcomas, as well as tumors arising more commonly in the breast, e.g. myofibroblastoma and fibrous tumors, and consist only of stromal cells. B. Fibroadenoma. Fibroadenoma is the most common benign tumor of the female breast. 2/3 of fibroadenomas harbor driver mutations in MED12. The pathogenesis of the remainder is uncertain. Morphology. Fibroadenomas vary in size from less than 1 centimeter to large tumors that replace most of the breast. They usually present as a palpable mass in young women and as a mammographic density, figure 23, or clustered calcifications in older women. The tumors are well circumscribed, rubbery, grayish-white nodules that bulge above the surrounding tissue and often contain slit-like spaces lined by epithelium. Figure 23b. The delicate and often myxoid stroma resembles normal intralobular stroma. The epithelium may be surrounded by stroma pericanaliculae pattern or compressed and distorted by it, intracanaliculae pattern. Figure 23. In older women, the stroma typically becomes densely hyalinized and the epithelium atrophic. Phyllodes tumor, like fibroadenoma, arises from intralobular stroma but is much less common. Cystosarcoma phyllodes is. Clinical features, a term sometimes used for these lesions, but Phyllodes tumor, most fibroadenomas occur in women in their 20-seconds and 30-seconds, is preferred. Since most behave in a benign fashion and they are frequently multiple and bilateral. These tumors not cystic. Like fibroadenomas, the majority of phyllodes are hormonally responsive and may grow in size during tumors have MED12 mutations. Benign appearing Phyllodes pregnancy and regress after menopause. Rapid growth and tumors that have only a slight propensity to recur, often infarction during pregnancy, may raise a false suspicion of have MED12 mutations and few other genetic changes. In carcinoma. Curiously, almost half of women receiving contrast, tumors that display malignant behavior are more cyclosporin A after renal transplantation develop multiple, likely to have mutations in additional genes, such as TERT, bilateral fibroadenomas that regress after cessation of treat, the gene that encodes telomerase. MENT. Whether these lesions are true neoplasms or reactive hyperplasias is unclear. Fibroadenomas are associated with a slightly increased risk of carcinoma, a risk that may be higher if complex features are present: cysts larger than 0.3 centimeters, sclerosing adenosis, epithelial calcifications, or papillary apocrine change. See Table 23.1. However, these changes are also associated with a higher likelihood of finding other lesions in the surrounding breast tissue, e.g. atypical hyperplasia, stroma covered by epithelium, figure 23, 24. In some tumors, these may be the true drivers of the increased risk. 1062. Morphology. Most Phyllodes tumors are detected as palpable masses, while a few are found by mammography. The tumors vary in size from a few centimeters to massive lesions involving the entire breast. The larger lesions often have bulbous protrusions. Phyllodes is Greek for leaf-like due to the presence of nodules of proliferating. See figure 23, fibroadenoma. A. Radiograph shows a characteristically well-circumscribed mass. B. Grossly, a rubbery, white, well-circumscribed mass is clearly demarcated from the surrounding yellow adipose tissue. The absence of adipose tissue accounts for the radiodensity of the lesion. C. The proliferation of intralobular stroma surrounds, pushes, and distorts the associated epithelium. The border is sharply delimited from the surrounding tissue. Phyllodes tumor, readings 1063. Adenomatous polyposis, hereditary desmoid syndrome, and Gardner syndrome. Malignant tumors of interlobular stroma. Malignant stromal tumors of the breast are rare. The only sarcoma that occurs with any frequency in the breast is angiosarcoma. However, it accounts for less than 0.05% of breast malignancies. Angiosarcoma of the breast may be sporadic or arise as a complication of therapy. Most sporadic angiosarcomas occur in the breast parenchyma of young women, mean age 35, and have a poor prognosis. Tumors occurring after treatment for breast cancer typically arise in older women and are associated with radiation therapy or chronic edema. After radiation therapy, approximately 0.3% of women develop angiosarcomas in breast skin, with most cases being diagnosed 5 to 10 years after treatment. Figure 23.2 for Phyllodes tumor. Compared to a fibroadenoma, there is increased stromal cellularity and overgrowth, giving rise to the typical leaf-like architecture. Other malignant tumors of the breast. Protrusions extend into a cystic space. This growth pattern also may occasionally be seen in large fibroadenomas and is not an indication of malignancy. Phyllodes tumor is distinguished from fibroadenoma on the basis of higher cellularity, higher mitotic rate, nuclear pleomorphism, stromal overgrowth, and infiltrative borders. Low-grade benign lesions resemble fibroadenomas but are more cellular and are mitotically active. High-grade, malignant lesions may be difficult to distinguish from sarcomas. Clinical features: most phyllodes tumors present in the 6th decade, 10 to 20 years later than the peak age for fibroadenoma. Most have low-grade benign cytologic features. These occasionally recur locally but do not metastasize. In contrast, borderline and high-grade, malignant phyllodes tumors often recur locally unless they are treated with wide excision or mastectomy. Regardless of grade, lymphatic spread is rare, and axillary lymph node dissection is contraindicated. The uncommon high-grade lesions give rise to distant hematogenous metastases in about 1/3 of cases. Only the stromal component metastasizes. Lesions of interlobular stroma. Tumors of the interlobular stroma of the breast are composed of stromal cells without an accompanying epithelial component. These include benign as well as malignant tumors, all uncommon and hence considered briefly. Myofibroblastoma consists of myofibroblasts and is unusual in that it is the only breast tumor that is equally common in males. Lipomas are often palpable and can also be detected mammographically as fat-containing lesions. The only importance of these lesions is to distinguish them from malignancies. Fibromatosis is a clonal proliferation of fibroblasts and myofibroblasts. It presents as an irregular, infiltrating mass that can involve muscle. Though locally aggressive, this lesion does not metastasize. Some cases are associated with prior trauma or surgery. Other cases occur as part of familial. Malignancies of the breast arising from lymphocytes or skin or metastatic from another site comprise less than 5% of breast cancers. Non-Hodgkin lymphoma may arise primarily in the breast, or the breasts may be secondarily involved by systemic disease. Most primary breast lymphomas are of B-cell type, while rare T-cell lymphomas may arise in association with breast implants, possibly due to chronic inflammation, which is known to stimulate lymphoma development in other contexts. Young women with Burkitt lymphoma may present with massive bilateral breast involvement, often while pregnant or lactating. Malignant tumors may arise from the skin and dermis of the breast. These tumors are identical to their counterparts found in skin elsewhere. Chapter 25. Metastases to the breast are rare and most commonly arise from melanomas and ovarian cancers. Key concepts: stromal tumors. Intralobular stroma is the origin of 2 biphasic tumors, fibroadenoma and phyllodes tumor. Fibroadenomas are the most common benign tumor of the breast. Tumors of interlobular stroma consist only of stromal cells and include both benign and malignant lesions. Angiosarcoma is the most common stromal malignancy and can either be sporadic or associated with radiation exposure, or lymphedema. Suggested readings: The Social, Historical, and Political Significance of Breast Cancer, Mukherjee S., The Emperor of All Maladies, A Biography of Cancer, 2011, Scribner. This look back at the evolution of our understanding of cancer includes the history of the discovery of HER2 and the remarkable impact of HER2 targeted therapy. It also includes a cautionary look at how clinical trials can go awry, as in the solid tumor autonomous marrow transplant program for breast cancer in the 1990s. Suggested. Chapter 23, The Breast. Olson J.S., Bathsheba's Breast, Women, Cancer, and History, 2002, the Johns Hopkins University Press, from Queen Atassa in Babylonia in 490 BCE to Dr. Jerry Nielsen in Antarctica in 1999. Women have diagnosed their own breast cancers for thousands of years. This is a chronicle of breast cancer as told by these women, as well as an informative history of the important milestones in cancer treatment. Yalom M., History of the Breast, 1998, Ballantine Books. Scholarly work on the cultural, political, psychologic, artistic, physical, and religious significance of the breast. General sources of information about breast cancer. Breast Cancer, Facts and Figures, American Cancer Society, 2018. Available at www.cancer.org. Excellent resource for up-to-date information about breast cancer. International Association of Cancer Registries, IACR, Globocan, 2012. Available at globocan.irk.fr. The International Association of Cancer Registries provides information about the incidence of cancer and mortality worldwide. Large Internet Breast Cancer Datasets. The Cancer Genome Atlas Project, cancergenome.nih.gov, accessed January 1, 2018. This is a National Institutes of Health sponsored initiative that includes information on over 800 breast cancers. The International Cancer Genome Consortium, icgc.org. Accessed January 1, 2018. This is a voluntary international group of scientific researchers and organizations. The Molecular Taxonomy of Breast Cancer International Consortium, Metabric. www.cbioportal.org. Accessed January 1, 2018. The original Molecular Taxonomy of Breast Cancer International Consortium included greater than 2,000 breast cancer samples from tumor repositories in the United Kingdom and Canada. This site also provides links to other databases. National Cancer Database, NCDB. www.fax.org. Accessed January 1, 2018. The National Cancer Database includes information on approximately 70% of newly diagnosed breast cancers in the United States from American College of Surgeons Commission on Cancer, accredited hospitals. Surveillance, Epidemiology, and End Results, SEER Program, http seer.cancer.gov. Accessed January 1, 2018. This is a program of the National Cancer Institute that collects population-based information from cancer registries, covering approximately 28% of the U.S. population. Breast Cancer Biology, Cassisant A.K., Schalk A., Zhao R. et al., Multiclonal Invasion in Breast Tumors Identified by Topographic Single-Cell Sequencing, Cell 172, 205, 2018. The powerful combination of morphology and single-cell sequencing allows the separate evaluation of ductal carcinoma, in situ, DCIS, and invasive carcinoma, and reveals that multiple different subclones arise in DCIS, invade the stroma, and contribute to the invasive tumor. Davalos V., Martinez Cardis A., Esteller M., The Epigenetic Revolution in Breast Cancer, From Single Gene to Genome-Wide Next-Generation Approaches. AMJ Pathol 187 2163, 2017. Epigenetics plays an important role in every aspect of breast cancer, from the determination of molecular type expression of estrogen receptor, to the activation-inactivation of growth signaling pathways, to the development of resistance to treatment. Del Alcazar CRG, S.J., Ekram M.B. et al., Immune Escape in Breast Cancer During In Situ to Invasive Carcinoma Transition, Cancer Discov 7 1098, 2017. Some breast cancers, especially ER-negative and HER2-positive types, are associated with prominent T-cell infiltrates. How these cancers escape from immune surveillance and how to modulate this response to enhance response to therapy are promising areas of investigation. Ellsworth Rhee, Blackburn H.L., Shriver C.D. et al., Molecular Heterogeneity in Breast Cancer, State of the Science and Implications for Patient Care, Sem and Cell Dev Bio. Single-cell sequencing has shown. Eighth, largest datasets with molecular information on breast cancer include these. These are large data repositories for clinical information about breast cancer patients, including types of cancer, stage, and survival. 164. That every cell in a breast cancer may be genetically unique. Heterogeneity is one of the major challenges in developing effective treatment strategies for cancer. Fleischer T., Techpli X., Mathelier et al., DNA methylation at enhancers identifies distinct breast cancer lineages. Nat Commune 8 1379, 2018. Methylation is an important mechanism of genomic regulation that underlies major patterns of gene expression, such as the expression of estrogen receptor. Geyer F.C., Parasia F., Weigel B. et al., The Spectrum of Triple-Negative Breast Disease, High and Low-Grade Lesions, AMJ Pathol 187, 2139, 2017. Although carcinomas that lack expression of hormone receptors and HER2 triple-negative carcinoma generally confer a poor prognosis, there are many subtypes within this group, including some with a very good prognosis. Hung Y.J., Lester S.C., TSA, GM, et al., The Molecular Basis of Breast Cancer Pathological Phenotypes, J. Pathol 241, 375, 2017. In this study using data from the Cancer Genome Atlas, the gene expression patterns underlying pathologic features are explored. For example, tubule formation correlates strongly with genes expressed by luminal cancers. Mardamshina M., Geiger T., Next Generation Proteomics and its Application to Clinical Breast Cancer Research, MJ Pathol 187 2175, 2017. DNA sequencing and messenger RNA profiling provide only part of the profile of a cancer cell. Evaluation of the functional molecules proteins has been more challenging, but new techniques should allow large-scale analysis. Rusness H.G., Lingard O.C., Boris and Dale A.L. et al., Breast Cancer Molecular Stratification, From Intrinsic Subtypes to Integrative Clusters, AMJ, Circ Pathol 187 2152, 2017. Modern classification of breast cancers includes alterations in DNA and messenger RNA patterns, protein expression, and the resulting phenotype as recognized as